Hi everyone, so this is our presentation. We were topic 6, which was talking about current or emerging public health concerns in a particular region. And we've chosen to have a little look at knife crime in the UK. Knife crime is on the rise in the UK. This has been the cry from the media, police, emergency services and hospitals for the past 5 years, citing an obvious upwards trend in the number of reported incidents of stabbings and knife crime. Knife crime is a devastating violent crime issue. Time and time again, there are news reports telling of how another young person has lost their life to knife crime in the UK. This issue has a devastating effect that extends beyond the individual who has been stabbed into the families, schools and communities surrounding that person, and also into other realms such as the emergency services and hospitals that encounter these tragedies. So we're going to look at some epidemiology of knife crime in the UK. Knife crime is classified in statistical terms as a low volume but high harm violent crime. When we're looking at data provided by the Home Office and the Office for National Statistics, it is evident that there is an increase in the volume of knife crime. A report from the Office for National Statistics for the year ending March 2018 demonstrated the highest recorded number of offences involving a knife or sharp instrument in the past 8 years. This is 16% higher than in 2016-17 and 23% higher than in 2010-11. This data is provided from two sources: Police Recorded Crime and the Crime Survey for England and Wales, which is a face-to-face victimisation survey looking at the respondees' experiences of crime in the 12 months prior. So when we're looking at the areas that knife crime is most common, it can be seen that knife crime tends to occur predominantly in metropolis areas. Knife crime data sourced from the Office of National Statistics demonstrates an overrepresentation of London when looking at knife crime by police force areas, with London showing 168 per 100,000 population for knife crime incidents, compared to the lowest area, which was in Surrey, which had 5 per 100,000. When we're looking at knife crime in relation to hospital attendances, we looked at NHS hospital data and what is called finished consultant episodes. So this is a total period of care experienced by a patient under one consultant in a single hospital. So the limitations of this data is that it potentially does not capture self-discharges from hospital for victims of knife crime, and it also doesn't capture people who don't actually attend hospital. However, despite this, the data shows that there was 5,053 finished consultant episodes recorded in English hospitals in 2017 to 2018 that were due to an assault by a sharp object. The data over the past 5 years also aligns itself with the data provided by the Office for National Statistics, demonstrating a clear upwards trend in the number of hospital attendances for victims of knife crime. So who is most affected by knife crime? Well, most of the perpetrators and victims of knife crime are over the age of 18, as you can see from this table here. However, there are still a significant proportion of people under the age of 18 who are involved in knife crime. So the hospital data we've just seen on the previous slide does show a large proportion of knife crime victims who are under the age of 30 years old. And even more alarmingly, a significant proportion of those are under the age of 18. In a report regarding the Mayor of London's 2017 knife crime strategy, data showed that of the 4,415 total victims of knife crime with injury in London in 2017, 46%, or 2,028, were aged 25 years and younger. They also cite the number of knife crime with injury victims under the age of 25 increasing by almost 25% compared to the previous year. In the year of 2018, of those convicted of knife-related offences, 21% were under the age of 18. It can be seen from this that one of the most significantly affected groups of this problem are young people. So, what contributes to knife crime? Well, there's a tendency to conceptualise knife crime as a gang problem. While gang-related activity definitely acts as a social determinant of the knife crime problem, it is certainly not the driving force behind the issue. Knife crime, flagged as gang-related activities, account for 5% of the total knife crime with injury during 2016. So we can see this issue as much more than a gang-related issue. So there are numerous social determinants that inform knife crime. These include socioeconomic status, previous experiences of violence, education and engagement at school, engagement in the community, and financial hardship, just to name a few. And this is why it's so important to conceptualise knife crime as a current and emerging public health concern within the UK. Through doing this and looking upstream to the determinants of this knife crime problem, governments, police, emergency services, schools, social services and communities can work together to have a preventative effect for young people experiencing knife crime rather than maintaining a reactive stance. So we've just had a look at the epidemiology of knife crime. I'm going to hand you over to Alice now, who will talk to you a bit more about what the current methods of dealing with this problem are in the UK.
My name is Alice, and my part of the presentation is particularly related to past government strategies and policy. So let's take a look at how the government has approached this issue. In order to take knives off the streets, an amnesty was organised and almost 90,000 knives were collected in the year 2006. The then Home Office Minister declared this as successful. However, consider this example. If every person in the UK had one knife, and the collected figure of 90,000 knives would only represent 0.004% of the 22 million households in the UK. Knives remain readily available. The new Offensive Weapons Act has made it illegal to buy, carry, or own weapons such as knuckle dusters, zombie knives, and Death Star knives. The stop and search policy was allowed under the Public Order Act of 1994. Members of the public were allowed to be searched by police in the anticipation of violence. In 2003, a report was released on the year 2001 to 2002, in which time 18,900 searches were conducted. The report found that only 7% of all the people searched were found to be carrying an offensive instrument, and only 14%, which is around 200 people, were arrested for possession. It is well documented that those targeted were often minority black and ethnic males, and this has resulted in resentment from both police and public. The Violent Crime Reduction Act of 2006 allowed teachers in schools and institutions the right to search anyone suspected of carrying a weapon. Previously, police would have had to be called to conduct a search, and those suspected could dispose of weapons and not be convicted. The Act was designed to aid police in the reduction of knife possession. But the Teachers' Union disputed this measure, as they believed the teacher's role is to teach and not to undertake searches that jeopardise the trust between teacher and student. In 2006, the Violent Crime Reduction Act doubled prison sentences for the carrying of a knife. The sentence went from 2 years imprisonment to 4 years. Given the hidden nature of knife carrying, it is hard to determine if these tougher punishments would indeed have a great effect. And further to this, the offenders are often children and young people, so would result in these groups going to prison for even longer. So some other current government measures to combat knife crime. An extra £100 million has been made available for police forces in England and Wales. Under the heading Early Intervention and Prevention, the Youth Investment Fund has been created to build resilience and life skills in young people. Under the heading Targeted Selected Intervention, the Early Intervention Youth Fund has been created to reach out to at-risk youth and to prevent them from becoming involved with violence. All of these measures are part of the Home Office's more recent approach to the issue of knife crime. The government is now investing more funding in the prevention rather than just the criminalising and punishment of offenders. But really, the past strategies of the government are not thorough enough in their approach to the issue. As referred to in a TED talk by Dr. Gary Slutkin, who is an epidemiologist, he says, "We reverse the impact of so many diseases, and we can do the same with violence. We need to be looking to science and public health strategies to stop it." Slutkin believes that the spread of knife crime is similar to that of disease and can be eradicated just as many diseases have been. So it's at this point that I will introduce you to Matt, who will present the current public health strategies to knife crime and the effect that they are having. Thank you.
If we take a public health perspective when looking at violence as a larger, more holistic problem, rather than isolated incidents that are solely a policing matter, we can see a positive trend throughout the world of this different approach having an effect. Take for example Scotland in 2004-2005. 137 homicides, 40 of which are in Glasgow, which is also once regarded as a murder capital of Europe. This more than halved to 59 throughout Scotland by 2017-2018. This substantial decline is internationally accredited and recognised as being due to Scotland's public health approach, with the Violence Reduction Unit being established in 2005. The VRU was based on the recommendations from the World Health Organization to slash the violence epidemic plaguing Europe. The World Health Organization also states that the evidence-based action and multi-sectorial cooperation is required for a public health approach. In London, a public health approach is becoming a current strategy for combating the knife crime epidemic. For example, Red Thread began in 1995 in Dulwich and has since expanded throughout the United Kingdom. In London, teenagers aged 13 to 19 have access to nurses, general practitioners, counsellors, and youth workers. The Youth Work charity initially came from a background of young people's empowerment and community and has since received widespread praise, including London's previous mayor stating that these specialist workers at the emergency frontline are helping to break the cycle of reoffending, offer young people the support they need to seek a way out of violent lifestyles, and making London safer for everyone. In 2005, Red Thread expanded into hospitals, launching the Youth Violence Intervention Program. This program runs an accident and emergency of major trauma hospitals across London. Youth workers aim to engage with and follow up 11 to 24-year-olds who come into A&Es victims of violent crime or assault. Engaging with these young people at such a crisis point is important in attempting to prevent ongoing knife crime and violence. They are encouraged to make ongoing healthy decisions and engage in the community in an attempt to halt the cycle of violent crime, re-injury, re-offending, and re-attendance. This public health perspective looks at violence as a larger, more holistic problem rather than isolated incidents that are solely a policing matter. It looks at violence as a product of a range of preventable factors. Some factors to consider when taking a public health approach include looking at a specific and defined population rather than specific individuals, as these populations can often have health determinants that link them, creating links between government and organisations and encouraging these organisations to work together rather than separating them, utilising surveillance and data collection to provide evidence-based platform to create and develop prevention strategies, working with and for communities, involving all aspects of the community in order to make this a more individualistic problem, addressing the root causes of the issue rather than reacting to the outcomes of the issue, focusing on creating preventative measures and strategies that are both short and long-term focused. If we talk about Dr. Slutkin again, when he gained funding to set up Cure Violence in Chicago, the first rule was that violence should be treated as contagious and not just a problem with bad people alone. From previous knowledge and experience as an epidemiologist, Dr. Slutkin knew one way to reach certain populations was through their own peers. He recruited former gang members, known as violence interrupters, to speak to the current ones, and the results were almost instantaneous. Crime in West Garfield, where all first began dropped significantly and a program was adopted across the city. Key to the success of the program was what we discussed before, looking at these specific populations and being separate from gangs and law enforcement, but also at the same time creating links and addressing the root causes. For example, we can see the effectiveness of this public health approach when we look at Chicago in 2015-2017, where cure violence funding was reduced. This negative impact of this became quickly apparent, with the city experiencing its deadliest year in 2016, with the violent crime homicide rate at its highest in nearly 2 decades. In 2017, the program regained its former level funding, and there was a 16% decline in violent crime homicides. This suggests a strong correlation between the holistic upstream approach advocated by Dr. Slutkin and reduction in violent crime. The Mayor of London, Sadiq Khan, gave £500,000 to London's Violence Reduction Unit and would focus on early interventions involving schools, healthcare professionals, councils and the police. Still, it doesn't seem that knife crime is reducing anytime soon, and with the alarming numbers over the past few years, the public health approach is slowly gaining traction, and it might be years until we see results. Based on the previous examples of public health approaches to knife crime, such as the Scottish public health approach and Dr. Gary Slutkin's epidemiological research into treating knife crime issues, we would recommend the continued funding and expanding of public health-based approaches in London and the UK towards knife crime. This could also potentially be extended to other parts of violent crime.
So that was our presentation. Thanks for listening, everyone. Here are our references if everyone or anyone is interested. If you have any questions, shoot us a question via the discussion boards or the Blackboard Collaborate. Hope you enjoyed listening.